loss can affect everyone from babies to our older generation, and the impacts of hearing loss are broad and can be profound. Solutions for hearing loss, tonight on Call with the Prairie Doc.
Hello and welcome to On Call with the Prairie Doc. Health information based on science, built on trust. I'm your Prairie Doc host, Dr. Andrew Ellsworth, and tonight we will be talking about solutions for hearing loss. Hearing loss can be caused by a variety of factors, both environmental and genetic. Whether it is exposure to loud noises over an extended period of time or aging, many things can contribute to the deterioration of one's hearing. It is important to seek medical attention if you are experiencing any signs of hearing loss, regardless of the cause. If left untreated, hearing loss can have serious consequences on a person's overall health and well-being. Tonight, we will discuss solutions for hearing loss and taking viewer questions. Thank you for joining us. This evening, we are joined in the studio by Dr. Greg DeSautel, who provides services in otolaryngology, and Teresa Fendrich, an audiologist. Both are from Avera Medical Group ENT, Head and Neck Surgery. Welcome and thank you for joining us on the show tonight. Dr. Greg DeSautel, if you don't mind giving us a little bit about your background and,
Sure.
and what you do.
So I'm Dr. Greg DeSautel. I've been an otolaryngologist for 27 years and have been in South Dakota most of that time. I've spent a little time in Iowa. I do primarily peds and otology at Avera in Sioux Falls, and have been, my claim to fame is that I actually put the first cochlear implant in South Dakota 27 years ago, I should say. So that's a little bit of my background.
That's amazing. How many have you placed?
Well over 300 probably. We do about 40 to 50 a year. I took a break in there a little bit to go work for the state of South Dakota, but other than that, I probably do about 40 cochlear implants a year.
Well, we will get more into cochlear implants a little later, but I know they can be life-changing, so thank you for coming on the show. And you've been on the show a couple times before.
Yeah,
That's
so
great.
Talking about different things. So
welcome back.
Thanks.
And Dr. Fendrich, tell us a little bit about yourself.
Yes, I'm originally from Rapid City. I have spent the last 23 years at Avera as an audiologist, and get to see patients of all ages. So we see and evaluate hearing and hearing loss from anyone from a newborn baby all the way up to over 100. So, yeah.
It's great having you on the show. I don't know how many audiologists we've had on the show before, but so important, especially for this topic, and so key for what you and your colleagues do to help determine what's going on with hearing loss. And we'll get into more of that in a little bit too, but thank you for joining us. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion about solutions for hearing loss. Viewers can contact us via 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask on our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we do not get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it is not required to submit a question. The winner will be drawn and announced at the end of this program. So to start with, let's talk about hearing loss. Teresa, if you don't mind, what is hearing loss? And when someone comes to you, what are you going to evaluate?
Yeah, so hearing loss can come in a variety of degrees. So there's a range of hearing, right? There's a range of normal hearing, and then there then slopes into hearing loss once you get outside that normal range. It can vary by degree. It can vary by the frequency or pitch that we look at. And we see people of all ages, so the hearing loss can be for our adults. Somebody may be coming in if they've noticed a change in hearing or are asking them to repeat. So those would be some signs of hearing loss. And then when they come to us, we'll just to do a hearing evaluation and take a look at what their hearing loss looked like and if it needs to be remedied.
Now, you know, some of these signs of hearing loss as we get older, we're turning the volume up and others are saying it's getting too loud, or, you repeat yourselves. And like you said, there's different frequencies. So sometimes some people have trouble hearing people that speak in higher pitches, or have trouble hearing women, or having trouble hearing their grandkids. Is that typically how it goes with hearing loss as we get older? That loss of higher frequency, or not necessarily?
Yes, as for aging, there's kind of two kinds of from aging with hearing loss. One is a very typical kind of a high frequency hearing loss. Some other can be kind of just a flat across all frequencies, but a very typical one is kind of you can hear well in the low pitches, so somebody's hearing, but then you slope off in the highs. And I think some of the first signs with those high frequency hearing loss is people will report having difficulty hearing in background noise, because we need our good high frequencies to hear well and do well in background noise. So, and it's a classic, complaints where people are not enunciating or people are not speaking clearly, and that's because they'll have good hearing in the low frequencies, so they can get some of the energy of speech, but they can't distinguish an F sound from an S sound. Did you say 52 or 62? That's very typical of a high frequency hearing loss.
So Greg, if someone sees you for hearing loss, they're going to be seeing the audiologist, and maybe they already did,
right.
But you're going to look at, there's such a wide variety of causes, and some things that maybe be a quick fix if it's a bunch of earwax or something.
Right.
But what are some of the things you're looking at then and considering?
So one of the first things we look for is asymmetry, because the typical aging hearing loss, somebody as they're getting older, it's pretty symmetric. Both ears are declining at the same degree. So when you see some asymmetry in one ear versus the other, then you start to create some red flags where you want to say, okay, maybe this was a hunter, so their left ear, the right-handed hunter, their left ear is a little more exposed to the gunshot, so maybe that's the reason for the asymmetry. Sometimes when you see a mixed pattern where now it's not just a nerve loss, there's also some conductive component to it. Are there some other mechanical things going on where the ossicles aren't working well? And so we need to be aware, cognizant of the difference between a conductive loss, which again could just be simply as fluid in the middle ear, it could even be just wax, and that causes the mechanical loss of hearing, or conductive loss is the more technical term for it. So I would say asymmetry. The other thing that we look for a lot of times is if their word understanding is not good. So we do a pure tone test with them, but we also want to know what their speech discrimination is. So if that starts to drop, if it's not 100%, if it's, let's say, less than 80%, then we also are a little bit aware of that and say maybe there's something else going on here than just the typical hearing loss of aging or as a result of noise exposure. And that's real variable, but the other thing is that points to us is whether they're going to be a good candidate for hearing aids, because if you can't understand words in a quiet environment, so cowboy, hot dog, if I can't understand those words, hearing aids may have some limitations, so you may have to counsel the patient a little bit. Hearing aids are very good nowadays. They're much better than they used to be, but they're not perfect. They're not going to restore that word understanding to 100%. So.
And so, hearing aids, now you can get some over the counter without a prescription, without a doctor. They might be handy or cheaper.
Right.
I mean, what are your thoughts on when someone's ready for hearing aids and if they should explore the over-the-counter ones?
Yeah, so over-the-counter, people kind of have two paths of entry into the hearing aid market. So traditional path where they would see me typically would be a hearing evaluation. We're going to look at their hearing and evaluate them and look and see if they're a candidate for a hearing aid. When they come to an audiologist, you're going to get we're going to get all those pieces and parts right, fitted right, optimized for you, kind of a fancier processing chip. We're going to take all the measurements to make sure that the hearing aid is optimized for your performance. So that's kind of the traditional route of the hearing aid purchase would be that way.
Which, to optimize, if they're having trouble hearing whichever frequencies, you can adjust that to fine tune.
Yes. So over the counter is kind of a very different pathway. So it's there's no really audiologist involved typically. They are going to buy it online or, and it's for perceived mild to moderate. You may take a hearing test online. And then you may get put into certain categories of where the hearing aid thinks you should have amplified. It's not customized with the fit, it's a more basic device, so it's probably a more entry-level starter hearing aid for situations where you may need a little bit of help in certain areas. So, yeah.
I wonder how often patients are happy with those.
I don't know, because we
Yeah.
don't typically see
Yeah.
them until
But
they're
I'm sure
ready
you've
to.
seen some
Yeah,
that,
yes, until when they are ready to
Yeah.
then say, you know what, I tried this, it doesn't fit my ear right, I'm not getting good benefit, it's not working, can you help me out? And then we can take it from there. Because I always say success with a hearing aid is kind of three things, right? It's your hearing loss and where you're looking to hear better. Where do you need to hear better? What problems are we trying to solve? It is the device. And then the other critical factor is how well it's fitted, right? We need to look at the size of your ear canal. We need to look at all the pieces and parts that make up that hearing aid. And we want to optimize the fit. So when you get a hearing aid, there's a prescription, believe it or not, for how much sound you should be getting with that hearing aid based on your hearing loss. And so when you come to us after we evaluate your hearing and we're going to fit you with a hearing aid, we're going to put you in front of a machine that's called a real ear verification system. We're going to put a probe in your ear, and we'll put the hearing aid in the ear. And we're going to measure and see what the output of the hearing aid is doing in your ear, and we'll adjust it to fit your prescription target. Sometimes we need a different dome or a size or a piece or different pieces and parts to kind of optimize the fit, because we need to get you hearing as much as we can based on your prescription.
And those hearing aids have made a lot of progress.
Yeah, and the one thing I would bring up is the hearing aid is as good as the person that dispenses it. So there's lots of different brands out there. There's a lot, sometimes you get asked, well, what's the best brand? And I would say it's whatever the audiologist is comfortable fitting you with, and where their expertise, because the companies are somewhat different in terms of what they can offer and the proficiency and the effectiveness of the hearing aid. So. There's hearing aid dispensers, and then there's just an audiologist, a doctor of audiology. And so I try to encourage my patients to go to a doctor of audiology, because they have the expertise to give you the maximal benefit from your hearing aid. You might pay a little bit more to go to a doctor of audiology, but it's like anything, usually you get back what you're willing to pay for. So. Yeah.
And I was just going to also touch on how hearing aids aren't what they used to be.
Yeah.
Could you touch on that too?
Well, yeah, I was joking earlier tonight. I mean, when I first got started in 1990, you had a hearing aid with the high frequencies would roll off. You couldn't even really get much in the speech frequencies. You took a screwdriver to the back of the hearing aid, and you usually had two trim pots that would maybe control the loudness of the output and a tone control, and that's it. So they would squeal, they wouldn't fit right. Now fast forward to today's hearing aids, where there's a very sophisticated processing chip that over 1,000 times a second is doing a scene analysis around your head, deciding what you should be hearing and how much it should amplify. Much better feedback control, so it's not squealing, much better noise reduction, just rechargeable. You can use your phone, an app on your phone to make adjustments. But a lot of times you can just put the hearing aid in and let the technology do its job. Once in a while you may need to control the volume, but
sure.
It's pretty fascinating. Yeah.
Got some good questions here. This one says, I have an older patient who's talking a little bit louder now. How and what are some of the other signs that he may be losing his hearing and should be evaluated? Well, we did touch on this some, but are there any additional things you'd add that signs that someone may be losing their hearing?
Go ahead.
So certainly it would be, some of the first ones are the TV is louder than what others would prefer. You find yourself asking others to repeat what was said. You may not hear the alarms or certain environmental sounds that others are hearing. And you may just be noticing that people are mumbling, right?
Yeah.
That people are just not speaking clearly and distinctly. And that is some classic signs of hearing loss.
I'd say the family members are usually the first people
Sure.
that perceive it. So daughter who says, Mom, you're just not hearing as well as you used to, you should take that for, as a sign that maybe I do have some hearing loss that I'm not aware of. And Selective hearing loss, is a different story, but that happens too.
This person asks how important it is to wear earplugs. I have a child that participates in music and is regularly exposed to loud noises. What would you say about that?
So that's critically important. I would say that noise protection from a young age is really important. Earplugs, if you go to any kind of sporting events, whether it be in a gymnasium or, especially these loud stadiums we kind of mentioned before, that they get extremely loud, and 90 seconds of intense noise exposure can actually cause hearing loss. So, earplugs are critical, whether you're mowing the lawn, chainsaws, anything you do as a part of your normal activities. A lot of times earplugs are beneficial. And I will say, we all sometimes wear like AirPods or something like that, and that can be somewhat protective as well, as long as you have the music that you're playing is at a reasonable level as well. So,
and I think that's important to point out how the duration of the exposure is so important. Mm-hmm. Yes, a loud gunshot is really bad, even just brief.
Right.
But some of those examples of mowing a lawn or at a sporting event can cause damage.
For sure.
It's definitely a time and intensity formula, so you can get sustained permanent, hearing loss with just a gunshot that goes off close to the head. But I've also seen aerobics instructors who 3 or 4 days a week are teaching aerobics for an hour at a time, and will have a noise-induced hearing loss from that. It takes a lot longer, and it's usually less severe, but it's still there. So I do, for our young kids, drum lines, all of that is just incredibly loud. And most kids have their phones. One of the things that you could do is, if you're worried, are you in an environment where it's too loud? Rule of thumb is if you have to talk above the noise to be heard and carry on a conversation, you should be wearing hearing protection. But there's also all kinds of apps that are a sound level meter. Pull out your phone and see where you're at.
Yeah.
If you're above 86, that's an 8-hour day, which requires hearing protection. But if you're, 90s and 100s, you should be definitely wearing hearing protection.
Absolutely. Well, most of us have seen or know someone who uses a hearing aid, but what if we need something more to restore our hearing? Prairie Doc spoke to an individual who has a cochlear implant and how she uses her disability to inspire others.
When Taya Hazelhorst was born, she failed her newborn hearing screening on the left side, and her mother, Ashley Hazelhorst, did not know why. She soon found out when Taya was 6 months old that Ashley had been sick with cytomegalovirus prior to becoming pregnant with Taya.
I didn't know that the virus was still active inside of me, and so we got pregnant with Taya, and that's when the damage or the virus kind of had attacked her. And so what happens is a lot of time is it affects their hearing, their vision, and their balance.
The virus affected Taya's hearing in her left ear and eventually took her right ear around 3 years old. Shortly after, physicians said Taya could qualify for a cochlear implant. A cochlear implant is a hearing device that attaches to the auditory nerve to send signals to the brain, but the nerve must be intact beforehand to work properly.
If the nerve is not always stimulated, then you can't do the surgery, or it won't likely work because the cochlear implant needs to be situated on the nerve. So without the nerve being functioning, the surgery would not be successful.
They attached the implant on the left side, and she wore a hearing aid on her right ear. It took many weeks for Taya to be acclimated.
When they activate it, they start at a very low volume, and it starts out, your brain has to adapt to the internal piece and figure out how it works. So it will start out with just beeping noises, or very monotone. There's no pitches, there's no voices, you can't understand words. So everything sounds very robotic, or almost like TV static.
Taya's implant worked for 7 years until it stopped working on Christmas morning when she was 11. She had her second implant surgery a couple weeks later, and her brain had to relearn how to use the auditory nerve. It was around this time when Ashley decided that her family needed to learn sign language.
At the end of the day, Taya's still deaf and hard of hearing. When you take those devices off, there's not a lot of, she cannot hear a whole lot. And so as a family, we've decided 4 years ago or 5 years ago to start learning sign language, so that way we can always communicate with Taya.
Throughout her life, Taya learned to advocate for herself and her needs, and has always been able to teach others as well.
Taya's learned to advocate for whatever needs she needs for hearing, like closed captioning. She'll have teachers that have a hard time figuring out closed captioning, and she'll teach them.
And she has used that ability to inspire other girls who are experiencing similar challenges.
I have met some little girls who also wear hearing aids, and this past year I've been trying to meet with them when I have time, or go to their schools and go read books with them, just so that they can see that there are other people just like them.
What a remarkable story, and what a remarkable young woman, and of course a remarkable device, a cochlear implant. If you don't mind, Dr. DeSautel, tell us a little bit about what's going on with the cochlear implant and what it does.
Okay, so cochlear implant basically is taking the sound energy, and this is a speech processor that takes the acoustic energy and actually puts it into an electrical energy that's actually then sent to the auditory nerve directly. So we're actually bypassing the cochlea. So that electrical energy then is stimulating, this is the cochlea here where the electrode will go into. It's actually stimulating the auditory nerve directly. But the cool thing about it is there's 16 plus electrodes that are actually stimulating at a different frequency. But it's even more complicated than that, because these electrodes, in between the interfaces of the electrodes, there's actually some additional programming processing that's happening for the cochlear nerve, so that the brain can process this sound as actually normal electrical energy. So we put this in. The cochlear implant surgery takes about 2 hours. It is pretty well tolerated, even by the elderly. I've done anywhere from 9-month-old all the way to a 94-year-old in terms of doing surgery. The kids do really well with it. They probably have a recovery of maybe a day or so. It's pretty amazing. The adults sometimes have some dizziness, and there's some ringing that goes on. We usually do the hookup about 3 to 4 weeks after. So this is put underneath of the skin and then goes into the cochlea, and then afterwards for the activation, we actually are going to put this on the skin like this, and then this part goes over the ear. But at the activation, especially in little kids, you'll see the light kind of come on. They can have a variety of responses as either a kid or as an adult to getting it activated and turned on. It does take, the cool thing about cochlear implants too is that you can have an initial, within the first month or 6 months, you're going to have some progression of sound and learning language and that kind of thing. For a kid, we always say it's like the day they've been born. So once they get the activation, it takes them about 6 months probably to gain some language. But it is rapid, and it continues to improve probably over the lifetime of that kid in terms of the processing and how much the cochlear implant will help them as they get older. And this is true for adults too. You may have, 5 years, they're probably maybe doing a little better than they were at 6 months after the cochlear implant was placed. So that's the cool part about it.
Yeah, it really is amazing, and like you said, it can be helpful for kids, obviously, and when their development and language development. But adults, I've got several adult patients with them, and you've got a ton. But I've seen it help them as well. Absolutely,
right,
it's really remarkable. And without them, with hearing loss, an adult or anyone can start to become more withdrawn and kind of just avoid social situations and avoid people and kind of get detached, and then that can increase the risk of depression and increase the risk of cognitive decline or dementia. And so it really can be helpful. Teresa, you're helping them through this process as well, and it's going to take some work. There's some therapy, there's some retraining in the brain that happens. Right. What do you do with them through that process?
As for cochlear implants?
Yeah.
Yeah, so just to clarify, and I think we talked about this before, most people have entry into hearing solutions through the hearing aid. And when we get to the point where a hearing aid is not going to benefit, then we'll move to the cochlear implant. So we do an evaluation, and we're going to look and say, are you a candidate? And usually it's a certain, even if their hearing aid is optimized they still have trouble with speech understanding. So that's how they'll qualify for an implant. We always talk through that, hey, you are a candidate for an implant. We think you're going to get some benefit from this. Kind of show them the equipment and talk about that. And if they're ready, we have manufacturers that have kind of pre-recipient solutions as well as people to help them after the implant. We always talk that they have to be ready for it, right? Because they can't just put the implant on and be ready to go. It is a learning process. So the day of activation, they're going to get the implant, and the goal for that day is sound awareness. They'll say, oh, it sounds like Mickey Mouse, or I think I can make out a difference between an E or an ooh. But fast forward a month or two later, and they will be able to, should see an improvement in their scores and speech understanding. But we have to tell them that they're ready for it, because we need to have them wearing the device for about 10.5 hours a day and minimum. And then there's a lot of homework that's required. So it's a lot of graduating in difficulty from listening exercises. So first just sound awareness, then it's maybe reading aloud, looking at a book so that they hear the sound and know what their brain is hearing is what this is in the book, to then more complex environments with talking with loved ones and so forth. So it's a process, and they have to be ready for it.
Yeah. Cost-wise, is this something insurance covers or not?
Yeah.
Or?
So it is covered by Medicare, it's covered by Medicaid, and private pay insurances, Blue Cross Blue Shield of South Dakota. Pretty much all the insurance companies are going to pay for the cochlear implant, and obviously you have a deductible, but yeah, almost all insurances now are covering cochlear implants. In kids, we actually do bilateral cochlear implants. So if you're born with profound deafness, the kid's going to have. In adults, we tend to do a unilateral, do one side, and then if they continue to qualify or have struggles, we might do a second cochlear implant. But yes, insurance does cover the cost of it.
It's really, really great. We've got several questions here. One thing we haven't covered on yet is tinnitus, that ringing in the ears. And this caller says, within the last 3 or 4 months, the callers had hissing in their ear consistently. What might be causing this? Is there a solution? And someone else asked from Garrettson, what things can be done to help tinnitus?
Well, I would say call and make an appointment to get your hearing evaluated. A lot of times it's hearing loss, and so we'll take a look at and do an evaluation. And if they've got tinnitus, what we'll do is do a hearing evaluation and then get some kind of parameters around the tinnitus, like what frequency is that tinnitus, how loud is it? And so, yes, get an evaluation, get tested. And if it's a sensorineural hearing loss that we're seeing and the tinnitus is in that region where the hearing loss is, it's a high likelihood that it is the brain trying to make up for what the ear is not providing it, right? It's knowing that the brain is looking for sound that it's not getting. And so we can put a hearing aid on, and oftentimes that'll really help them.
Yeah, it's remarkable to think that because we can't hear, our brain is giving us something to hear, whether we like it or not.
The brain knows that it's looking for sound from the ear that it's not getting, and it's trying to do all it can to rectify that. So it's increasing that neural activity to try to make the connection to the ear where there's hearing loss. So the solution is, a lot of times, is just to aid them. But basically, if you do nothing else besides put a hearing aid in and fit that loss, then the brain is like, okay, I got what I wanted, I'm going to quiet down. That doesn't help when you have to take the hearing aid out when you go to bed at night. So we talk about other management solutions. If there is hearing loss there, we talk about management strategies such as avoiding complete silence.
And so maybe turning on white noise when you go to bed.
Yeah, whatever works to kind of just take the edge off of quiet, because you'll notice the ringing more when it's quiet.
Now, what happens when someone's gotten hearing aids and they're still having ringing in the ear problems?
So that's a big challenge, because there really isn't any medicine that's going to make a difference for the ringing in their ears. So sometimes you can do some biofeedback, sometimes even cognitive behavioral, like psychotherapy, can be helpful to help with that management of the ringing. Because really, at some point, when hearing aids aren't helping, it's managing the ringing. And sometimes depression is caused by the ringing. Sometimes depression or anxiety will exacerbate the ringing. So sometimes you have to manage the underlying symptoms with, you know, behavioral therapy. Even sometimes medicine for treating the depression might help with actually managing your ringing. If you're feeling better about yourself, you can tend to cope with other things better. So, you know, it's a hard thing to tell a patient that they're going to have to live with their ringing, but sometimes you have to, you know, help them to cope with it. But basically, that's the bottom line. Ringing, and that's what, you know, it brings us back to the noise protection. It's like, what causes ringing there? Well, it's hearing loss usually from noise exposure. So if we're more aware of protecting our hearing from a young age, we're less likely to get ringing when we get old. Yeah. So it just kind of goes back to that noise protection and how important that is. Because if you have ringing that's really annoying and keeping you up at night, that's a challenging situation for many patients.
This caller from Sturgis, along the same lines, caller has thumping in their ears. Mm-hmm. What might that be with thumping? So
thumping, sometimes you have a little stapedial muscle that actually will sometimes, you have muscles in the ossicles. So if you look at your little ossicles here, there's actually muscles that are attached both to the stapes and to your malleus. And sometimes thumping is actually a myoclonus. It's like the activation of that muscle. The muscle is just going into like twitching. Literally, it's twitching. And so sometimes you can go in with a laser and cut that muscle, or sometimes people will try medical therapy as well for that. But thumping, I'd have to see the patient to say, could be pulsatile tinnitus too. Sometimes you can hear your heartbeat in your ear, which most of the time is totally normal.
Sure. Yeah, it can be a warning sign.
It can be a warning sign, but for high blood pressure and other things, for sure. Yeah. But I would say, you know, a lot of us will go to bed at night, and if we're under a little bit of stress, we'll, and you know, put our head on our pillow, we're going to hear our heartbeat a little bit. So, nothing to worry about if that's the case.
This person asks, any good hearing aids for people with cookie cutter hearing loss? You know, we have touched on hearing aids pretty well, and I'm not sure what they're saying. I guess what they're saying is just regular hearing loss, I suppose. I'm not sure exactly.
Yeah, I don't know if they're talking cookie cutter or cookie bite, because audiology talks about a cookie bite configuration. So yeah. A cookie cutter hearing loss, I suppose, would be just, so maybe I'll answer it two ways.
Yeah, feel free.
So cookie cutter would be your, you know, standard hearing loss, and again, we want to look at that hearing loss, see what it is, and fit the aid to that prescription. Yeah. So we want to just get a hearing aid and optimize that fit no matter what the technology is. Yeah. A cookie bite hearing loss is one, so you know, you've got the audiogram with low to high pitches and soft to loud, right? So most people, you know, we talked about that good low frequency sloping to the highs. A cookie bite looks like this. Oftentimes it's genetic, but you still fit it the same way, right? You're going to look at that hearing loss and we're going to say, okay, this is how much sound we need. We're going to fit the hearing aid to match those targets. The tough ones are the reverse slopes where they've got terrible low frequency and rising to normal, and those are a little bit trickier to amplify.
Yeah. This person says, I have an aging parent who will not wear hearing aids because he is embarrassed by them. How do I impress upon him the importance of hearing, and how he will be less frustrated if he wears them?
Well, I would say to all people that healthy aging means being able to hear. So we do know there's big risk factors of hearing loss and cognitive decline. And then we also talk about a cognitive load, right? When you're working really hard to hear, your brain is expending a lot of energy doing that. If we take off the cognitive load by helping you hear better, it's going to free you up to do other tasks, right? So.
And it's really huge. It really is, because we have a limited mental capacity, and if we're using all that capacity to hear somebody, you can't underestimate how freeing that can be for the patient when they hear well, and now they're not using all that energy to try to hear. Yeah. It's a really important point.
It's hard, you know, you try to get the buy-in, at least maybe suggest, can we start with an evaluation, because they have to be ready, you can't force somebody, but certainly, just pointing out, I notice you're really struggling to hear, you're not hearing the grandkids as well, you're missing out. We want you to be part of our family, and we want you to be part of this conversation. And Yeah, healthy aging means being able to hear and stay involved.
Absolutely, thank you. Like a lot of products, there seems to be an abundance of hearing aids on the market. Prairie Doc spoke with audiologist Dr. Brett King, who showed us how she navigates this process for her patients.
A hearing test is medical first and foremost. We are looking at and ruling out any medical concerns with the ears and with the hearing.
An audiologist tests and determines the patient's sensitivity to sound. This test is a pure tone test. It consists of beeping sounds at various frequencies. From there, the doctor observes how the patient hears speech along with other sounds.
Hot dog. Airplane.
If hearing aids are recommended for the patient, they work to find what would work best.
So once we know your hearing status, we consider that in what will work for your prescription.
There are various types of hearing aids. They are primarily broken down into two categories.
One that goes only in the ear, and then the other kind goes behind the ear. We decide the style based off of a few things, but mainly the severity of the hearing loss.
Lifestyle factors also help decide which type of hearing aid style is best for the patient.
The hearing aid selection process is an important one. More important than that is adapting to using and wearing the hearing aid.
One challenge for someone using hearing aids for the first time is getting used to the sound they offer.
The brain gets really comfortable with what it knows. If it's used to a hearing loss, it's comfortable with the hearing loss. Well, we flip that upside down, more or less, when we introduce new sound, the sounds that the patient was missing. And it can take up to 6 months for the brain to fully adjust to hearing aids.
How long it takes to adjust to a hearing aid depends on how long the individual has had a hearing loss, the degree of hearing loss, and their personality.
We really try to make hearing aids as simple as can be.
So we had one question here, do we always have to see an audiologist to get hearing aids? And we touched on over-the-counter ones, but to maximize your benefit, it's going to be helpful to see an audiologist, I guess.
Yeah, so there are audiologists and there are hearing aid dealers. Both are licensed in the state to provide hearing aids. They do just differ a little bit in terms of the training and schooling involved, but both are qualified to dispense hearing aids. Those would be still hearing dispensers, and audiologists would be the more traditional route to get the hearing aids. And then there's the over-the-counter variety where perceived kind of a DIY hearing aid and perceived mild to moderate hearing loss.
And like you said, some of the other places that are selling them, as long as they're working with you and giving you good service, I mean, that can be something to look for too.
Yeah, and yes, absolutely. Someone that's there to help kind of troubleshoot and keep the hearing aids running and so forth. I would say the real ear verification, like we saw in the video here, those are really just critical to ensuring a good fit.
And as far as insurance coverage, how will insurance cover hearing aids?
Some do, a lot don't, so that really just varies. We're starting to see a lot of the Medicare replacement plans having some kind of benefit. We do try to offer a wide variety of prices to meet a variety of price points, so we can go kind of high dollar, very expensive and sophisticated processing, down to still a very good hearing aid that can be well fit, but maybe less bells and whistles, but is still a solid performing hearing aid that has been optimized for your hearing loss.
We've got some other great questions. We'll see how many we can get through here. This person says, I read that I should not be using Q-tips. Why do I need to not use them, and what are my other options if I have earwax?
So this is an interesting discussion. I would say the reason not to use Q-tips is because a lot of times you're actually pushing the wax further in, and you're maybe whatever you see on the Q-tip is about half of what's actually in your ear canal. And we find that occasionally too, people will perforate their eardrum because they either get bumped or they're, don't walk and use a Q-tip kind of thing, and they accidentally, push the Q-tip through the eardrum. So most of the time, because wax is actually it's antibacterial, And so you really, some wax in the ear canals is actually beneficial. It keeps you from getting a swimmer's ear or otitis externa, which we really haven't talked about. But cerumen in general is beneficial, and it's going to clean itself. If you don't push it in with a Q-tip, most of the wax, and I usually recommend, like even in babies, like just take a washcloth with some soap and water and just whisk out whatever you can get. You can do that as an adult. There are some interesting over-the-counter kind of things, ways to do wax removal, irrigation. There's a suction kind of thing. Those probably aren't going to hurt anything, and they can be helpful at times. So sometimes, but in general, Q-tips are probably not the best solution for getting wax out. And a lot of times, if you just leave it alone, it's going to come out.
But yeah, some of those over-the-counter ones can be harmful. I mean, a suction thing. If you move the pressure too much, it could be bad for the eardrum.
Ear candling.
Ear candling.
Yeah, please stay away from ear candling. If there's anything I can tell you, it's hocus pocus. Okay, you're like, save your $25 and just do something different with that money, because it really is not making a big difference for you. It might feel good, which is fine. If you want to spend $25 to feel good, I guess that's okay.
Just try not to burn yourself.
Yeah, I've seen somebody that lost their eardrum from ear candling, so I'd really try to avoid that if you can.
Sounds good. Best, if you can, leave them alone if they're not bothering you.
Yeah, for sure.
Can vertigo and hearing loss be connected? This caller asked.
Absolutely,
Yes.
yeah. I mean, hearing loss and vertigo, the first thing we do in any patient that comes in, and vertigo really is a symptom of like room spinning. So there's lots of, dizziness and vertigo. People sometimes don't understand the difference. But vertigo is true room spinning, like you laying down and the room's going round and round, or you roll over in your bed and the room's going round and round. That's vertigo, but it's a symptom, not a diagnosis. So a lot of times the first thing we do with somebody who comes in with room spinning or vertigo is do a hearing test, because they can be associated or correlated. In general, I would say most patients don't have hearing loss who have vertigo. Vertigo is like the lone symptom. So I'd say the vast majority of patients probably, but like Meniere's disease is going to give you vertigo and a low frequency sensory nerve hearing loss. So it's really important to get your hearing checked, because there are things that we can do for somebody who, let's say, has Meniere's disease. So yeah, definitely they can be associated. I'd say Meniere's disease is probably the number one thing we see, the association between vertigo and hearing loss.
And labyrinthitis.
And labyrinthitis, yeah. Sometimes you can have a bacterial labyrinthitis, so that can be, you actually need to really treat that aggressively if somebody has bacterial labyrinthitis. So.
Go see your doctor.
Go see your doctor, yes.
This email says, I recently experienced some hearing loss from some medicine I was taking, but now has come back. Is this something that will happen anytime I take that drug? Do I need to be careful with drugs in that family as well?
Yes. So the question is, like, high-dose aspirin is probably the number one association with, there's ototoxic medications. Most of them are like chemotherapy agents. Sometimes we'll have ototoxicity, with the fancy name for ear damage or hearing loss is ototoxicity. So, but yeah, and they probably should stay away from that medication. I would say the vast majority of people, medicines are pretty safe and don't often cause hearing loss other than, the high-dose aspirin. But there are gentamicin, there are some antibiotics that will cause hearing loss as well. So you got to be careful, especially the IV, like gentamicin really can be significantly ototoxic. So you got to be careful of some of those.
Yeah, I'd just add that most of the time, if someone's taking an aspirin every day, it probably should just be an 81 milligram aspirin. Mm-hmm. There's not many indications for higher than that and be hard on the stomach. Even could be bad for your hearing.
Yeah.
For your ears. This email says, could the doctors talk about assisted listening devices? Granted, we've talked about hearing aids and we've talked about cochlear implants, but there are some other assisted listening devices.
Yeah, so what we look at when we approach somebody with hearing loss, our number one thing is are we going to amplify? So we're going to start with a hearing aid or then move to the cochlear implant. What solutions what all problems can we take care of by doing that first? And then if we're still struggling, we're going to pull in other devices to help. So I have certain people that when they go to bed at night, they have significant hearing loss and they live alone and they can't hear the smoke alarm. Mm-hmm. And so we will get some kind of a device to help them do that. Some of the more common ones are going to be like a TV streamer, so you can do a Bluetooth connect that to your TV and then stream right to your hearing aids. That's a great sound quality, so that's an assistive listening device. Some of the other ones are like remote microphones. So what we talk about with hearing aids is hearing aids are meant to like help in this conversation just like our ears would. But if distance or noise is a factor, then the hearing aid is not going to do as well in that environment. Those are the kids that would get like an FM system in the classroom, or there's some that can be used out in the community too, where the person that you want to talk to or hear is going to wear the microphone device, and then that's going to go into the hearing aids. So that's another assistive device. And then there's other ones out there. I would say the TV, the remote microphone, alert and alarming devices are the most common in terms of assistive devices.
Along some of those same lines, this person says, I have trouble hearing my phone when I have my hearing aids in. What can I do about that to hear it better?
When the hearing aids are in, hearing the phone. Boy, I'm not sure without knowing the specifics there. Typically, if you've got the hearing aid and a smartphone, we're going to pair your hearing aids to your phone and then turn the volume up. So sometimes you just have to turn the volume up or the ringer up on your phone, because streaming, like talking this way versus, but that's hearing your phone ring? Is that what they said? Hearing the phone
Well,
ring?
I think just hearing, just talking on the phone maybe.
Or talking on the phone.
You may just need hearing aids that are actually going to Bluetooth to the phone. I'm wondering if
so then you don't even hold it up to you, because it's going right to.
It's going to go right through. So what we try to do is, if you've got a smartphone, we're going to use that and just stream directly into the hearing aids, and that actually works really, really well. And then if they have just like a flip phone or something, then it might be some troubleshooting, like, you know, when you have a hearing aid here, the microphone's here, maybe you need to know, like, okay, I've got to put the phone here where the microphone pickup is.
One more about hearing aids. Is there a difference between in the ear and over the ear hearing aids?
It's mostly just by style and preference. So I would say the majority of the hearing aids that we do now are the receiver in the ear style, which have the piece that go over the ear with a thin piece. They're advantageous for a lot of reasons. Number one, they look nice. Number two, there's a lot of pieces and parts that we can replace in the office and keep working. Things like if it's not working, we can send it to the manufacturer and they don't fix it. They usually just send a replacement device. Those are often the receiver in the ear, over the ear, lend itself really well to rechargeable. So those work for a lot of people. In the ear can work for certain types. Sometimes you may be limited based on the physical characteristics of your ear canal, or if you've got really good low frequency hearing and in the ear is a little bit trickier. But they both can technically do the same thing.
Yeah.
They're just a matter of comfort and style and preference too.
This person says the audiologist they consulted for hearing loss said that Parkinson's probably causes hearing loss because it's a neurological disorder. Have you ever heard of that? Is there association with Parkinson's, or? Not sure.
I guess I haven't really heard
I'm not
of
aware
that.
of that. I mean, yeah,
Mm-hmm.
not aware of the specifics. I mean, Parkinson's can affect, you know, a lot of different nerves, but there's not a real strong correlation between Parkinson's and hearing loss.
This person says they were approved for cochlear implants this past July at a different location. They want to continue the process here. What do I do? They're in Frederick, South Dakota. What can they do to?
Avera ENT, they just call the office. We'll set them up with a evaluation and see if they're a candidate, and if they are, we can, you know, do that. So I would say the surgery is, you know, it's a pretty straightforward process. They don't need a referral from their physician. They can actually just call the Avera ENT line, get an appointment, and we'll get them set up and see. There's a little bit of a backlog, but we'll try to do it as soon as we can if they call the office. So.
I do think sometimes patients are afraid that they can't do anything without a referral. And there's so many things that you can do. Just call who you're interested in seeing and try to get an appointment.
Sure.
It's good to work through your primary care doc, and they'll probably assist you through the process better. But don't be afraid to make that call if you feel like you need help.
For sure.
Yeah, we take self-referrals. And then on that cochlear implant, would they need a hearing eval within 6 months?
Yeah. So we try to do so
it's been greater than 6 months.
We try to do it within 6 months. Sometimes if we see them at 6 months, then the surgery might be, you know, at 8 months or something, since they got their, it's a little arbitrary.
This person says they damaged their eardrum, but they can hear fine now. Sometimes it fades a little. should they do anything about it, or can they leave it alone?
The amazing thing about the eardrum is, like, most punctures are going to heal. Probably 98% of somebody who's either from an infection or, let's say, they punctured their eardrum while they were water skiing or something like that, the vast majority of those are going to heal. And the fact that they don't have any hearing loss tells me that nothing really to worry about. So.
Sounds good. So in our last minute or two here of the show, some final words of wisdom, if you don't mind, for all our viewers out there to protect their hearing and such.
Yeah, so I would say if you're number one, protect your hearing. So prevention is key. Just keep hearing protection wherever you might need it. So next to your mower, in your glove box, maybe in your purse, just so it's always there. I would also advise that if you're suspecting you have some hearing difficulties, don't wait. Get help, come in, get evaluated. There's lots of solutions and things that we can do to help. So.
Yeah. And I would probably just echo that, is that, don't be afraid to go in, and even if your hearing is normal, that's okay, because a lot of times perception, just that reassurance that the hearing is actually normal. If you're perceiving like I have a hearing loss or I have some hearing issues, there's no harm in coming in. The audiologist isn't going to, we're not going to make fun of you because you come in and you have normal hearing. I mean, really, we're there to reassure a lot of patients that their hearing is normal, that things are, and you might have a little bit of intermittent ringing in your ears. So you're wondering, is there something serious going on or not? A hearing test can really help to sort through that. Same thing with like dizziness or any of those other symptoms, is just don't be afraid, even if you're told that things are normal. That's okay. That's a lot of times why we're there, and that's what, a lot of what our job is reassurance, as I've heard you say before. So.
And what do you like to do? What do you enjoy most about what you do?
What do I enjoy? I do enjoy the cochlear implant when the patient comes back and they're either their child or as an adult, they go from a situation where they're socially isolated to where they're now engaged and they're actively participating in conversations in the family. They're hearing their grandkids again. So for me, that's one of my greatest. I get a lot of rewards because I get to deal with kids, and I do a lot of pediatrics where I just put in PE tubes, and a sleeping mom is a happy mom, and if she's sleeping from that, I'm just telling you, PE tubes make a world of difference for a lot of parents and marriages as well.
Thank you very much, both, so much for joining us on the show tonight. Our winner for our prize is Terry. A book will be sent to you shortly. We'll be back after this.
Grab a copy of your local newspaper or read online the Prairie Doc Perspective, a weekly health and medical column. Head to prairiedoc.org to access all archived columns today.
Thank you to our guests, Dr. Greg DeSautel and Dr. Teresa Linde-Fendrich, for volunteering their time to help us learn more about solutions for hearing loss. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online. Listen to us on Prairie Doc Radio on SDPB Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with Prairie Doc, thanks for joining us for another episode of health information based on science, built on trust. Until next time, stay healthy out there, people.
Join us this week as we host one of our viewers' favorite shows, Ask Anything. The show focuses on all medical topics affecting those in our viewing audience. Ask Anything, next time on Call with the Prairie Doc.
My name is Jennifer May, and I serve on the Healing Words Foundation Board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello, possibility. Hello, healthy. Hello, life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,